Welcome to another ABC compliance video. Now that we've covered the basic elements of the anesthesia charge calculation, it's time to ask the question, what other services or treatment options were provided that require a separately billable code? What services and charges are not bundled into the primary charge calculation? In this module, we will explore the specific documentation requirements for those separately billable services that anesthesia providers may perform. In order to understand what other services require separate billing together with the anesthetic during a given episode of care, one must first understand a few basic facts about medical billing. Every medical service is classified with regard to how it will be billed and paid. As we've seen, anesthesia services reflect a calculation involving base units, time units, modifier units, and a conversion factor, which is the multiplier used to calculate the charge. All other services are paid based on a fee schedule, meaning the ASA units have no impact on the amount paid. Typically, an anesthesia provider will bill for 3 additional types of services: surgical, radiological, and medical. Invasive monitoring and nerve blocks are billed as surgical services and may be subject to what are referred to as multiple surgical payment rules. In other words, there are rules for what codes may be billed together. Guidance services such as ultrasonic guidance and fluoroscopy are billed as radiologic services. Rounding charges for follow-up visits to patients are billed as medical services, often referred to as E&M, or evaluation and management charges. Why does the type of service matter? There are specific rules for how each type of service gets billed. Probably the most important factor is determined by the Correct Coding Initiative, or CCI. Essentially, the CCI is a file that indicates all possible combinations of procedure codes. Every possible option is identified in one of 3 ways: always permissible, permissible only under certain circumstances, and never permissible. The fundamental concern in the calculation of an anesthesia charge is what is separately billable. Since the base value for an anesthetic includes all the usual services involved in preparing the patient and determining the anesthesia plan, then it would not be appropriate to bill separately for the preoperative assessment. Some services have been identified as invasive and requiring more skill to perform, and others are not. Thus, the rules allow for a separate bill to be submitted for the insertion of an arterial line, but not the placement of pulse oximetry or a BIS monitor. There are also specific rules and guidelines with regard to the requirement of a modifier when separately billable services are involved. All radiologic services, for example, have 2 parts: the professional component and the technical component. In billing for ultrasonic guidance, a 26 modifier must be included to indicate that only the professional component was provided by the anesthesia provider. Then there is the concept of multiple surgical payment rules. When 2 or more codes of the same type of service are billed, then only the one with the highest RVU value is paid at 100% of the allowable. The second and subsequent services are paid at a lower percentage. Interestingly, invasive monitoring charges for A-line, CVP, and Swan-Ganz catheter are exempt from the multiple surgical payment rules. Knowing the rules regarding when multiple services can be separately billed is a critical function of ABC coders. It's also their job to know when the documentation requirements for each service have been met. The use of invasive monitoring in TEE is the most common example of this. The typical cardiac case will involve the insertion of an arterial line in the radial artery, a central venous pressure line in the armpit or neck, and the floating of a Swan-Ganz catheter into the heart. Because of the CCI edits, the arterial line and the Swan-Ganz catheter are generally always payable, while the CVP is generally only payable if it was not used as the introducer for the Swan. The use of transesophageal echocardiography, TEE, reflects a most intriguing coding convention. Code 93313 is used when the only service performed was the placement of the probe for diagnostic purposes. 93312 requires that the provider both place and monitor the probe and prepare a report assessing cardiovascular function based on the information provided by the probe. For those of you who regularly perform TEE, make sure that you are current with your Medicare guidelines. Local carrier determinations are constantly being revised. Make sure you have a current version. While the use of invasive monitoring has been quite consistent across the country for the past decade or so, the use of nerve blocks for purposes of postoperative pain management has increased dramatically. We have also seen the increased use of ultrasonic guidance for needle placement. This creates increased risk for external audit and therefore becomes more important to ensure compliance with the required criteria and documentation. Anytime there is a dramatic increase in claims for a given service, it gets the attention of payers who want to know why. This has prompted ABC to monitor the documentation for these services very closely, and providers are well advised to pay close attention to the requirements necessary for blocks and ultrasonic guidance to be billed. Most anesthesia practices now use ultrasonic guidance for the administration of nerve blocks. This technology greatly enhances the provider's ability to visualize the anatomy associated with the block. Payers have come to recognize the value of this tool, and therefore it's a payable service. While the use of ultrasonic guidance has become a standard of service, which may mean that payers start bundling the ultrasonic guidance into the payment of the block, for now it remains a separately billable service. Because it has become such a commonly used service, payers are concerned that its use is appropriate. Guidelines for the documentation of ultrasonic guidance have been refined over the past couple of years. In addition to noting that the image is available for purposes of a potential audit, there must be a report explaining why ultrasonic guidance was used. An example would read something like this. Ultrasonic guidance was used to visualize the brachial plexus for purposes of performing an interscalene block for postoperative pain management. In addition to the services discussed thus far, many providers will round on patients postoperatively for the management of pain related to the use of a catheter or Duromorph injection. There are specific requirements that must be met. First, the visit cannot occur on the same day as the surgery and cannot be related to the anesthetic provided, as would be true of routine post-op care. Must happen after midnight. Rounding on patients with an epidural involves the use of 01996, while rounding on patients with other catheters or those who had long-acting Duromorph injections will be billed with a subsequent hospital charge, 99231, 232, 233. The documentation must reflect the 4 elements indicated: exam, pain assessment, future plan, provider. As always, be mindful that the services you are providing are medically necessary. For the service to be appropriately billable, the documentation must specify who the provider was, when the service took place, and what the status of the patient was. Thank you for participating in this ABC compliance program. We hope the information presented here is useful to you in understanding the requirements of compliant billing. We greatly value your comments and feedback on this program. For more information, feel free to write to jody.lock@anesthesiallc.com or even to call 619-249-9801. Please pass along any comments or questions you may have to the ABC Compliance Department at compliancehelp@anesthesiallc.com.